Namaskar. The brain, it's our own personal universe, right? So complex, so vast. But what happens when that universe gets hit by, say, a catastrophic event? Well, today, we're going to look at exactly that. What happens when our central nervous system comes under attack? And this is a really critical question. Because you see, unlike a broken bone that can heal, when the brain breaks, it can change the very essence of who we are. So what exactly goes wrong inside?
So get ready, class. I'm your professor for today, and we are about to dive deep into the pathology of the central nervous system. And to do that, we have to start with the first responders on the scene.
To really understand what happens in an injury, we must first meet the cells on the ground. Think of them as the brain's own emergency response team, okay? First up, the star player, the neuron. And here is the most important the fundamental point you have to remember. Mature neurons are post-mitotic. In simple terms, they don't divide. Once a neuron is lost, beta, it is gone for good. There are no replacements. This is an absolutely crucial point that shapes everything else that follows. But you see, neurons never work alone. They have a whole dedicated support team. Think of astrocytes as the diligent repair crew, always fixing things up. Microglia are like the resident security guards, cleaning up all the debris. And oligodendrocytes are the electricians, providing that vital myelin insulation. It's a real team effort inside our heads. So what happens when a neuron dies? Well, the astrocytes rush in. They multiply, they get bigger, we call this hypertrophy, and they form a dense network. This process is called gliosis. And listen carefully, gliosis is the most critical indicator of injury in the central nervous system. It is basically the brain's way of forming a scar. So the cells are responding, they're trying to help, but this response can create a much, much bigger problem. You see, the skull is a fixed box. It's rigid. It cannot expand. So when the brain inside it starts to swell, well, it becomes a very dangerous pressure cooker. And this is the result, cerebral edema. Just look closely at this image. Do you see how the brain's natural folds, the gyri, are all flattened out? The brain is swollen and has absolutely nowhere to go, so it's pressing hard against the inside of the skull. This is a critical, life-threatening emergency. So how does this swelling even happen? Well, there are two main ways. Let's make it simple. Think of it like this. Vasogenic edema is a problem with the pipes. The blood vessels become leaky and fluid escapes into the space between the brain cells. Cytotoxic edema, on the other hand, is a problem with the houses. The brain cells themselves get injured and swell up with fluid. And very often, both are happening at the same time. Now, another huge pressure problem is hydrocephalus. The brain has its own plumbing system for cerebral spinal fluid, the CSF. If this plumbing gets blocked, the fluid backs up, and the brain's internal chambers, the ventricles, they swell up dramatically, just like you can see right here. It's a plumbing disaster. When this pressure becomes too much, the brain starts to squeeze through any little opening it can find, literally like toothpaste from a tube. This is called herniation, and it follows a deadly domino effect. First, subfalcine, then transtentorial, and finally, the most life-threatening one, tonsillar herniation, where the brainstem itself gets compressed. So what on earth could cause such a dramatic buildup of pressure? Well, often it's the result of one single catastrophic event, a cerebrovascular accident. You probably know it by a simpler name, a stroke, or as we should really call it, a brain attack. Simply put, a stroke is brain injury because of a problem with blood flow. It can be from a blockage, which we call ischemic, or from bleeding, which is hemorrhagic. Today we are going to focus on the most common type, by far, the ischemic stroke. So what causes a blockage? Let's think of the brain's arteries as highways. An embolism is like a traffic jam caused by a car from another city. A clot travels from the heart and gets stuck. Thrombosis is a local problem. A clot forms right there on a damaged bit of the highway wall. And small vessel disease is like chronic traffic jams in all the small local roads deep in the brain. And here we can see the two potential outcomes. On the left, you see a pale, non-hemorrhagic infarct. That's from a clean blockage. But on the right is a hemorrhagic infarct. This is what happens when blood flow returns to the damaged area, but the vessels are so weak they just leak, causing bleeding into the already dead tissue. After a stroke hits, the brain tissue doesn't just disappear. Oh no, it goes through a very specific evolution. The first changes begin within hours. Then, the cleanup crews arrive in a couple of days. Over weeks, the whole area actually liquefies, becoming like a gel. And months later, All that's left is a cavity and a scar. Let's look at the microscope level, shall we? Within just 6 to 12 hours, we see this: red neurons. These are the very first visible casualties. You see, the cytoplasm is intensely red. The nucleus is shrunken. This is the first sign that tells us this neuronal death is irreversible. A few days later, the cleanup crew arrives in full force. In this microscopic view, you can see these foamy macrophages literally eating the dead tissue. And all around, new blood vessels are beginning to form as the brain desperately tries to repair the area. And this is the final stage, months later. The cleanup is complete. All the dead tissue has been removed, leaving behind a fluid-filled hole, a cystic cavity. And around its edge is that dense glial scar formed by the astrocytes that we discussed earlier. This damage, you see, is permanent. So the crucial point is this, and I want you to really get it. It all connects. A single blocked artery sets off a terrible chain reaction. Neurons die, the brain swells, pressure builds up inside that closed box of a skull, and this can lead to herniation and death. It is a truly devastating cascade. We've seen today that the brain has a remarkable ability to clean up and scar over after an injury, but it cannot regrow what is lost. Those neurons, the memories, the functions they controlled, they are gone forever. So the final question is for you. Knowing how fragile this whole system is, how will you think about protecting your own brain?
Hello, students, and welcome. Now, the human brain, it's our command center, no doubt. But what happens when this very important center comes under attack? Today, we are going to explore the 3 biggest threats to our central nervous system. We'll look at everything from sudden blockages to, well, devastating physical impacts.
It's a scary thought, isn't it? Our brain is protected inside a bony skull, but you'll see it is surprisingly fragile. By understanding exactly how it can be damaged, we can get a much better sense of why it is so critical to protect it. So here is our plan for today. We'll start with strokes, then we'll move to physical trauma, and we'll finish up with infections of the central nervous system. And at the end, we'll wrap up with the key points on how to protect our most vital organ.
Okay, let's dive right in. The brain's main vulnerabilities fall into 3 major categories. First, problems with its blood supply, which we call vascular. Second, physical damage from trauma. And third, attacks from tiny invaders, which are infectious. These 3 really cover the most common ways our brain can find itself in very serious trouble. So, what exactly is a stroke? I want you to think about it in a simple way. Think of it like a critical plumbing problem inside your head. You can either have a blocked pipe, which stops the blood flow, or you can have a burst pipe, which causes a flood. In both cases, the result for the brain tissue around it is, well, it's catastrophic. Let's start with that plumbing system. When the blood flow in the brain fails, we call it cerebrovascular disease. And let me tell you, it's one of the most common and devastating neurological problems that we see anywhere in the world. The first kind of plumbing failure is a blockage. The medical term is an ischemic infarct. So when a blood vessel gets clogged, the brain tissue that it supplies is starved of oxygen and nutrients. And without that vital supply, you see, the brain cells, they simply start to die. This image is very interesting. It shows something called a watershed infarct. Just imagine the brain's blood supply is like an irrigation system for fields. If the main water pressure drops, which fields will dry up first? The ones at the very end of the pipes, correct? The same thing happens in the brain, in the zones that are furthest away from the major arteries. Now, the other type of stroke is when a blood vessel actually bursts, and this causes a bleed inside the skull. This is a hemorrhage. And here you have a double problem. The area the vessel was supplying is now starved of blood, and the blood that is leaking out starts to build up, creating very dangerous pressure on the brain. Now, what's fascinating here, and very important for you as future clinicians, is that where the bleed happens is a huge clue to why it happened. You see, high blood pressure often causes ruptures deep inside the brain. But another condition, called cerebral amyloid angiopathy, it weakens the vessels closer to the surface. So for a doctor, the location of the bleed is a critical piece of the puzzle. And you can see that difference so clearly in these images. On the left, you see that deep bleed, which is very typical of high blood pressure. But on the right, the bleed is right near the surface, a hallmark of that amyloid-related problem.
It's a very stark visual of how two different diseases can create two very different emergencies. Bleeds can also be caused by something called an aneurysm. The best way to picture it is, imagine a weak spot on a tire or on a balloon. It bulges out, getting thinner and thinner until, poof, suddenly it bursts. When this happens in an artery in the brain, it causes a catastrophic bleed. And this is the devastating result. That huge bleed you see is a subarachnoid hemorrhage, very often from a ruptured aneurysm. Patients who experience this, they often describe a sudden, explosive headache, the worst headache of their life. It is a true medical emergency. All right, so beyond problems with blood flow, the brain is also very vulnerable to physical force. This is brain trauma, a major cause of death and disability, particularly in younger people. So what is actually happening during a head impact? Well, the brain itself is soft, almost like a jelly, and it's floating inside the hard skull. When the head stops suddenly, the brain keeps moving and it slams into the bone. That first impact is the coup injury, but then it can bounce back and hit the opposite side of the skull, causing a second contra coup injury. This image shows the terrible result. Notice the bruising on the lower surfaces of the brain? That is because the inside of the skull is not smooth. The brain is actually scraping against these rough, bony ridges, and that causes severe damage. Now, when trauma causes bleeding around the brain, there are two critically different types. And believe me, understanding the difference between them can be a matter of life and death. And here is that critical difference. An epidural hematoma comes from a torn artery. I want you to think of it like a broken fire hydrant. It's high pressure, very rapid bleeding. But a subdural hematoma, that comes from a torn vein. That's low pressure, a much slower bleed, more like a leaky garden hose. One is an immediate surgical crisis, the other can be much more subtle. These images show exactly what that looks like on a scan. On the left, you see that tight, lens-shaped epidural bleed from an artery, and it's pushing the brain's covering away from the skull. But on the right, the venous subdural bleed is spread out in a crescent shape following the curve of the brain. These are classic shapes that you must learn to look for on a scan. Okay, finally we come to our third major threat, infections. You see, the central nervous system is a very carefully protected space. So when microorganisms like bacteria or viruses manage to get inside, it is an extremely serious situation. One of the most well-known of these infections is meningitis. This is when the protective membranes covering the brain, the meninges, they become infected. So suddenly, the very layers that are meant to defend the brain become a source of dangerous inflammation. This is a powerful image. It shows just how dangerous that can be. That cloudy layer you see, that is not fog. It is a thick blanket of pus covering the surface of the brain. This puts immense pressure on the brain and can even block the circulation of the fluid that is supposed to cushion it. And here is a very interesting clinical point. The type of bacteria that causes meningitis often depends on the patient's age. This allows us, as doctors, to make an educated guess and start the right antibiotics immediately, which is absolutely critical. For example, the likely culprit in an infant is completely different from the one in a young adult or in an elderly person. Okay, we have covered a lot of ground today. Let's quickly recap the key takeaways from our look at the brain under attack. So, what must you remember? First, a stroke is a plumbing problem, either a block or a bleed. Second, in head trauma, the key difference is a fast arterial epidural bleed versus a slower venous subdural one. And third, with meningitis, the real danger comes from that inflammatory layer of pus that smothers the brain. So I will leave you with this final thought. We've seen today just how fragile our most important organ really is. So the real question is, knowing all of this, what can we do, as future doctors and as a society, to better protect it? Thank you.
Chalo bachcho, let's dive into a very fascinating and frankly a very serious topic. What happens when pathogens, these tiny invaders, manage to get inside our most protected organ, the central nervous system?
Now look closely at this image. The brain, it's like a fortress. It's meticulously protected by the skull and the blood-brain barrier. But as this picture clearly shows, its walls can be breached. These pockets, you see, these abscesses, this is clear evidence of a successful invasion. So in today's session, we are going to look at the culprits, their methods of attack, and of course, the damage they leave behind. And we'll start with the heavy hitters, bacteria and fungi.
Right. Now, when it comes to bacteria, you have to understand that they don't always play by the same rules. Their attacks on the brain can be broadly classified into two main strategies. So, on one hand, you have the swift, very focused assault of an abscess, a very localized, intense battle, you can say. And on the other hand, you have the slow, grinding siege of a chronic infection like TB, which spreads much more diffusely.
Think of an abscess like this. It's a walled-off bacterial colony right inside the brain parenchyma. The body, it tries its best to contain it. But in doing so, it creates this pocket of pus and dead tissue, which leads to immense pressure and, well, a lot of destruction.
So, the crucial point here is that the infection often starts somewhere else in the body. It's not originating in the brain. It might travel through the bloodstream, maybe from the lungs, or it could extend directly from an infected sinus. Or sometimes it can even get in through a head injury. The brain, sadly, is often the final tragic destination.
And this image, it brilliantly illustrates the consequence. See, it's not just the abscess itself that's the problem. Look at the surrounding tissue. That's what we call vasogenic edema, basically swelling, which is caused by leaky blood vessels. And this swelling can increase the pressure inside the skull to fatal levels.
Okay, now let's move to the chronic infections, like tuberculosis, which present a totally different kind of threat. Instead of a single mass, TB can create a widespread kind of gelatinous inflammatory exudate, especially at the base of the brain. And this can choke off crucial nerves and blood vessels.
Now, unlike the brute force of bacteria, viruses are stealth agents. They're much more strategic. They often target very specific cells and very specific regions of the brain.
This slide shows the classic signs of the brain's immune response to a viral invader. On the left, you can see lymphocytes forming a cuff around a blood vessel, and on the right, the microglia are forming nodules. These are the telltale microscopic signs of viral encephalitis. It's like finding fingerprints at a crime scene.
Take herpes simplex virus, or HSV-1. It has a terrifying preference, a favorite spot, you could say, for the temporal and frontal lobes. You can see the necrotizing damage right here. This specific targeting is why it affects functions like memory and behavior so profoundly. And if we zoom in with a microscope, we can actually see the evidence of the virus hiding inside the brain cells themselves. These dark spots, these are Cowdrey type A inclusions. They're essentially viral factories that have been set up right inside the neuron's nucleus. Then, of course, there is rabies, which has a truly sinister method. It actually uses the nervous system as a highway, traveling retrograde, backwards, along the axons from a bite wound all the way up to the brain. And its signature finding under the microscope is this, the Negri body. It's an eosinophilic cytoplasmic inclusion, and you find it in specific neurons, like the Purkinje cells of the cerebellum. Seeing this is pathognomonic. That's a key word. It means if you see this, it confirms the diagnosis of rabies 100%.
But what happens when the invader isn't external? What if the body's own immune system turns on the brain? Now this is a civil war, an autoimmune attack on the very system that is supposed to be protected.
And this leads us to demyelinating diseases. The most common example of this is multiple sclerosis, or MS. It's an autoimmune disorder where the body's own immune cells specifically target and destroy the myelin. The analogy is perfect. It's like stripping the insulation from an electrical wire. The nerve impulse just can't travel properly. This slide uses a special stain, Luxol Fast Blue, which makes healthy myelin appear deep blue. Now, that large, pale area you see in the center, that is an MS plaque. It is a battlefield where the body has completely destroyed its own myelin. In an active lesion, we can actually see the immune system's foot soldiers. These are macrophages, and they look foamy because they are literally filled with the lipid-rich debris of the myelin sheath that they are actively eating up. This comparison is key. On the left, no blue stain. The myelin insulation is gone. Porangile gayab. But on the right, a different stain shows the brown axons. The wires themselves are still relatively intact, and this relative preservation of axons is why MS patients can experience periods of remission, when the inflammation subsides. So with all these different attackers, bacteria, viruses, even our own immune system, how do we even begin to distinguish them? For this, a lumbar puncture is absolutely critical. We look at the cerebrospinal fluid, the CSF, for clues.
Now, this chart is critical for your diagnosis, so pay close attention. This is very high yield. The pattern of cells, protein, and glucose in the CSF gives us vital clues. For example, look, viral meningitis usually shows a high lymphocyte count, but the glucose is normal. In contrast, in TB meningitis, you often see very high protein and potentially low glucose. So this analysis, it helps guide our treatment. It tells us whether we're fighting a virus or bacteria or something else entirely. It's like having a window into the otherwise inaccessible central nervous system.
And that leaves us with a critical question for the future of medicine, a question for your generation of doctors. We can identify these culprits, yes, but often after the damage is already done. So how can we improve our surveillance and diagnostics to spot these invaders earlier, before the fortress is completely overrun? Thank you for your attention.
All right, everyone, settle down, settle down. Namaste. So today, we have a very, very important topic, neurodegenerative diseases. And listen, this isn't just for your theory exams, okay? This is what you will see day in and day out in the wards. So let's get the concepts crystal clear. So think about this for a second. You have a patient with memory loss, another one with these uncontrollable tremors, and then you hear about something totally bizarre, like mad cow disease. What could possibly connect all of them? They seem completely different, no? Well, that's where pathology comes in. We're detectives, and today, we're going to find the hidden clue that links all these cases.
Okay, first things first. Section 1. Let's define our enemy.
So, what's the definition? It's right there. Progressive loss of groups of neurons with shared functions. The most important funda to remember here is that this is not a random attack on the brain. No, no. These diseases are very specific, almost like snipers. They target particular groups of neurons. Think about it. That's exactly why Alzheimer's messes with memory, and Parkinson's messes with movement. It's all about which group of neurons is under attack. Simple concept, but absolutely crucial. All right, section 2. So what is that common link I was talking about? Well, it all boils down to a folding problem, a problem of proteins taking the wrong shape. Let's get into the nitty-gritty of it. And here is our villain of the story, protein aggregates, the common thread. See, in almost all these diseases, the basic problem is the same. Normal, hardworking proteins, they suddenly decide to fold incorrectly. They get the wrong shape. And once they're misfolded, they become sticky, like chewing gum. They start clumping together, forming this garbage inside the brain that the poor neurons just can't get rid of. This is why we call them proteinopathies. Simple, right? Pathology of the protein. Okay, look at this. This is our most wanted list, the rogues gallery. For prion diseases, the culprit is PRPS. For Alzheimer's, it's a double trouble situation with A-beta and tau. For Parkinson's, this fellow alpha-synuclein is the main problem. And so on. You see the pattern here? The criminal is different in each case, but the crime is exactly the same, misfolding and clumping together. Remember this table. It's high yield.
Okay, section 3. Let's open our first case file. And this one is really weird. We're talking about prion diseases.
Now look at this H&E slide. Look carefully. See all those holes, all those empty spaces? It looks like a sponge, right? This is the classic pathognomonic finding. You see this, you think prion disease. It's called spongiform change. And those holes, those are vacuoles inside the neurons, a direct result of that toxic protein accumulation. It's literally eating the brain from the inside out. So how does this happen? The mechanism is, frankly, it's terrifying. It's like a zombie movie at the molecular level. You have one bad prion protein, the PRPSC. It just touches a normal, good PRPC protein. And bam, the good one turns bad, it misfolds, and now you have two bad ones. They go and convert two more. It's a chain reaction, a domino effect. One bad apple spoils the entire basket, and it happens exponentially fast.
And what's the result for the patient? The most common human prion disease, Creutzfeldt-Jakob disease, CJD. And you have to understand, this is not the slow dementia of old age. This is a freight train, a rapidly progressive dementia that is 100% fatal. Once the symptoms start, the average patient survives for only about 7 months. It's devastating. All right, moving on. Section 4. Let's talk about the big one, the most common neurodegenerative disease you will ever see in your practice, Alzheimer's disease. Now, in Alzheimer's, it's a classic two-pronged attack. It's a double trouble pathology. Look here,
On the left, you see these ugly clumps outside the cells. Those are the A-beta plaques, extracellular. But that's not all. On the right, you see these flame-shaped things inside the neuron. Those are the neurofibrillary tangles, made of tau protein. So the neuron is getting attacked from the outside and the inside, a war on two fronts. So where does this all start? The leading theory is the amyloid cascade. It begins with a normal protein, APP. Think of it like a long ribbon. It's supposed to be cut by one type of scissor, alpha secretase. But in Alzheimer's, the wrong scissors, beta and gamma secretase, do the cutting. And this wrong cut produces a small, sticky piece of rubbish called A-beta 42. This is the stuff that clumps together and forms those plaques, kicking off the whole terrible process. And after all that microscopic mess, what does the brain look like to the naked eye? Just look at this. It's heartbreaking. On the left, a healthy brain. Plump, full. On the right, the Alzheimer's brain. It's shrunken, atrophied. The gyri, the folds, are thin like a knife's edge. The sulci, the gaps, are wide open. This isn't subtle. This is massive cell death visible right there on the gross specimen. Okay, last case file for today, Section 5. We're shifting gears from memory to movement. Let's talk about Parkinson's disease. And what's the story here? Surprise, surprise, it's another misfolded protein. Look at this neuron. See that perfectly round, pinkish blob in the cytoplasm? That, my friends, is a Lewy body. This is the diagnostic hallmark. If you see this, you know you're dealing with Parkinson's. And what's it made of? Our old friend from the Rogues Gallery, alpha-synuclein. Now, this image, this says it all. Look at the cross-section of the midbrain on the left. See that dark stripe? That's the substantia nigra. It's dark because it's full of pigmented neurons making dopamine. Now, look at the brain from the Parkinson's patient on the right. The stripe is gone. It's pale. Why? Because those neurons are dead. No dopamine. And that is why you get the tremor, the rigidity, the slow movements. The cause is right there in black and, well, not black anymore. So is it just about alpha-synuclein? Well, that's the main actor, but it has accomplices. We now know that other things go wrong in the cell. The mitochondria, the power plants of the cell, they start failing. And the cell's own cleaning crew, the autophagy lysosome pathway, it gets overwhelmed and breaks down. So think about it. The cell is producing more garbage, which is the alpha-synuclein. And at the same time, the garbage disposal system is on strike. It's a recipe for disaster. Okay, so we've looked at 3 major diseases: prions, Alzheimer's, Parkinson's. Let's step back and look at the big picture. What is the final take-home message for you guys? It all comes down to what we call the protein apoptothy principle. This is the key concept. First, there's a common mechanism, protein misfolding. That's the core of the problem. Second, the type of protein that misfolds decides which disease you get. Third, these clumps of protein are toxic to the neurons. And fourth, and this is a really hot area of research, it seems these bad proteins can spread from one cell to the next, almost like an infection, a prion-like spread. Understand this principle and you've understood the basis of all these diseases. So this leaves us with the big question, the billion-dollar question, really. If we know the villain is a specific misfolded protein, can we target it? Can we create drugs that go in and clean up this mess? Can we stop these diseases before they start? This is the central question in neurology today. And finding the answer? Well, that's the challenge that your generation of doctors will face. So study hard. Thank you.
Hello, good morning, everyone. Settle down. Welcome to our session on neuropathology. This is Chapter 28, Part 5. Today, we're not just going to be students, okay? We are going to be detectives. We're putting on our pathologist hats to solve some of the trickiest puzzles that happen inside the human brain. So get ready. We're about to step into a world where things are not always what they seem.
Okay, let's start with a very typical case. Imagine a patient walks into your OPD. He's moving very slowly, what we call bradykinesia. He has that stiffness, rigidity, and maybe some tremors. Immediately, what do you think? Your mind jumps to the textbook diagnosis. Parkinson's disease. It's a classic presentation, isn't it?
But wait, hold on a minute. This is where the real detective work has to start. Because what looks, smells, and feels exactly like Parkinson's might actually be a very clever imposter. Welcome, everyone, to the world of atypical Parkinsonian syndromes. It's a completely different ballgame. Now we have a name for these disorders, Parkinson plus syndromes. And that little word plus is the most important part.
It means the patient has all the Parkinsonism symptoms, plus a whole lot of other problems that just don't fit the classic picture. And this highlights the biggest clinical challenge for you as a doctor. You see, with classic Parkinson's, the drug levodopa, or L-dopa, can work wonders, nah? But for these plus syndromes, the response is minimal. The drugs just don't work as well. This is a huge, huge clue for us, the detectives, that we are dealing with something much more complicated.
So, to figure out what's really going wrong, we have to go from the patient's symptoms all the way down to the microscopic level. The real culprits here, the real villains, are proteins that have gone completely rogue. So let's investigate this tale of two very badly behaved proteins. You see, normally, proteins in our body are like perfectly folded paper airplanes, right? Each one designed for a specific flight path, a specific job. But in these diseases, the proteins misfold. They become useless, sticky little balls of junk. On one side, you have the tauopathies, where the main gunda is a misfolded tau protein. On the other side, you have the synucleinopathies, where the villain is misfolded alpha-synuclein. Basically, it's the same crime. Sticky proteins messing everything up, but it's two different gangs causing all the chaos.
All right, let's focus on investigation on one of these synucleinopathies, multiple system atrophy, or MSA. This one is particularly interesting for us pathologists. And this slide gets to the heart of the mystery of MSA. What are you seeing here? These brown smudges? These are clumps of that alpha-synuclein protein. But just look where they are. They're inside oligodendrocytes, which are the support cells for our neurons. Now, here's the puzzle. Alpha-synuclein is a neuronal protein. So what is it doing inside the wrong type of cell? It's like finding the cook in the engine room. This is the pathological hallmark, the dead giveaway for MSA.
Okay, now let's completely shift gears. We are leaving the world of misfolded proteins and entering the world of a faulty genetic code. This is Huntington's disease, and its mechanism of destruction is totally different.
Huntington's is a truly devastating genetic condition. It's autosomal dominant, which means you only need one copy of the bad gene from one parent, and that's it. The disease is certain. It causes these jerky, uncontrollable, dance-like movements we call chorea, along with dementia, as it just systematically destroys a part of the brain called the striatum.
So what is this genetic mistake? It's something called a trinucleotide repeat expansion. Basically, inside the Huntington gene, the HTT gene, there's a sequence of 3 DNA letters, CAG. And in this disease, that sequence just repeats itself over and over and over again. It's like a genetic stutter, CAG, 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 CAG. A healthy person might have, say, 10 to 35 repeats, but someone with Huntington's can have 40, 50, even over 100. And here is the really crucial part. The more repeats you have, the earlier the disease will start.
And here you can see the tragic result, plain as day. On the left, that's a normal brain. Now look to the right, the brain of a patient with Huntington's. Just look at that difference. Can you see how those central structures, the striatum, have just shrunken away to almost nothing? The ventricles, those fluid-filled spaces, have become huge just to fill the empty gap. This is the physical proof of that genetic stutter, a straight line from a faulty gene to the massive destruction of the brain.
Okay, for our final case today, we look at a disease that isn't defined by a specific protein or a single gene type, but by the very specific cells it decides to attack, the motor neurons. This is amyotrophic lateral sclerosis, or ALS. The definition is tragically simple. In ALS, the motor neurons just die. These are the command wires that run from your brain, down your spinal cord, and out to your muscles, telling them what to do. When these wires are cut, the connection is lost. The muscles become weak, and without any signals, they just wither away. This slide shows us those thinning wires with shocking clarity. Just have a look. At the top, you see healthy, thick, plump anterior nerve roots coming out of the spinal cord. These are the motor nerves. Now look below. In a patient with ALS, you can see how thin and wasted away they've become. They look like old, frayed threads. This is the physical disconnection happening right in front of our eyes. This is why patients lose the ability to move, to speak, and finally, to breathe. Now, here's what's really fascinating. Even within this one disease, which is defined by a specific type of cell dying, the underlying causes are incredibly diverse. Familial ALS can be caused by a mutation in the SOD1 gene, or a repeat expansion in a gene called C9orf72, similar to Huntington's, but a different repeat, or mutations in proteins that bind RNA like TDP43 and FUSE.
There are more than 24 different genetic starting points that all lead to the same tragic destination.
So, let's quickly summarize our investigation. We've uncovered 3 major patterns of crime, you could say, in the brain. First, we have the case of the misfolded proteins, the sticky culprits like tau and alpha-synuclein causing traffic jams inside the cells. Second, we have a faulty genetic code, like that stuttering CAG repeat in Huntington's. And third, a targeted attack on a very specific cell type, like the motor neurons in ALS.
And this brings us to the final and maybe the most important question. We've seen that the brain can break down in so many different ways, through so many different pathways. So as future doctors, as future scientists, where should we focus our efforts? Do we go after the protein, the gene, or do we try to protect the cell itself? That, my friends, is the multi-billion-dollar question. And honestly, it is the puzzle that your generation, your batch, will have to solve. Think about it. Thank you.
Hello, students, and welcome. Today we are going on a special tour, a microscopic safari, if you will, into one of the most complex topics in pathology, tumors of the central nervous system. Okay, let's dive into this. So here is our roadmap for today's session. We'll start with the gliomas. Then we'll cover the embryonal and neuronal tumors. After that, it's the meningiomas, and we'll finish up with a look at metastases and some important family syndromes. First up, the gliomas. You can think of these as an inside job. Why? Because they are tumors that arise from the glial cells, the very cells that support and protect our neurons. We're going to begin with the most aggressive of them all, the glioblastoma. Now, on an MRI, it often shows this ominous-looking ring enhancement. It's a classic sign, and you absolutely must be able to spot it. That bright ring is the active growing tumor, and the dark center, that's all dead necrotic tissue. Now, what's really interesting about this slide is how the macroscopic view on the left, with its chaotic, bleeding appearance, is actually explained by the microscopic view on the right. You see how the tumor cells are lining up? We call this palisading, and they're lining up around areas of dead tissue. This is a hallmark finding. So for your exams, the 2 crucial points to remember are these: necrosis and microvascular proliferation. These are the hallmarks. The tumor grows so fast, it literally outgrows its own blood supply, causing the necrosis. But at the same time, it's frantically trying to build new blood vessels to feed itself. Okay, let's move on to the oligodendroglioma. Look closely, Bacho. Do you see it? The cells have a clear halo around the nucleus, giving them this classic fried egg look. And notice that delicate chicken wire network of capillaries. Very, very characteristic. But you know, what truly defines this tumor today isn't just how it looks, it's its genetic signature, the 1p/119q co-deletion. You have to remember this. It's a very high yield point for your practicals and theory exams. This genetic change is a key predictor of how the tumor will respond to chemotherapy. Now for a different kind of astrocytoma, the pilocytic astrocytoma. This is a CNS WHO grade 1 tumor, which means it's much less aggressive. It's often found in children, and as you can see, it's typically cystic. You get this cyst with a little solid nodule of tumor on the wall. And this slide brilliantly illustrates its key feature under the microscope. Look at these bright pink, corkscrew-like structures. These are called Rosenthal fibers. If you see these on a slide, you absolutely must think of pilocytic astrocytoma. It's a spot diagnosis. Finally, to round out the glioma family, we have ependymomas. As the name suggests, they arise from the ependymal cells lining the ventricles. Their signature feature is this arrangement of tumor cells around blood vessels, which forms what we call paravascular pseudorosettes. All right, let's move on to our next category. These are tumors made of very primitive, undifferentiated cells, which is why we so often see them in children. Under the microscope, they're the classic small, round, blue cell tumors. The most important tumor in this group, without a doubt, is medulloblastoma. By definition, it occurs exclusively in the cerebellum, and it's considered a CNS WHO grade 4 tumor, so highly malignant. Microscopically, it's a classic small, round, blue cell tumor. On the left, you see just sheets and sheets of these primitive-looking cells. Sometimes they form these little circles we call Homer-right rosettes. But look at the right. You can see the more aggressive variant with larger, more irregular, angrier-looking cells.
So the crucial point here is its location in the cerebellum and its really nasty tendency to disseminate through the CSF. This can cause drop metastases down the spinal cord. And today, the prognosis is heavily dependent on its molecular subtype. So far, we've been inside the brain parenchyma, right? We've been talking about the insiders. But what happens when a tumor grows on the outside from the meninges? Well, that brings us to our next stop, meningiomas. These are the outsiders. These tumors arise from the meningothelial cells of the arachnoid layer, one of the protective coverings of the brain. Grossly, they are typically these well-defined masses that are attached to the dura, just as you see here. And this is a very important distinction. They compress the brain rather than infiltrating it. This makes a huge difference for the surgeon. Now here's a beautiful and very characteristic finding in many meningiomas. These things are called Samoma bodies. They are small, concentric calcifications. The name actually comes from the Greek word samos, which means sand, because they can make the tumor feel gritty. For your exams, please remember that these are usually benign, they're more common in females, and they are very strongly associated with mutations in the NF2 gene, which is on chromosome 22. That's a classic question. Okay, finally, let's briefly cover two last topics. Tumors that don't start in the brain but travel there, and the syndromes that put patients at a higher risk for these tumors. Now remember this, metastatic tumors are actually the most common intracranial tumors in adults, way more common than primary brain tumors. And where do they come from? The most common primary sites by far are the lung and the breast. And you absolutely must be aware of these key familial syndromes. Each one is associated with a specific set of CNS tumors. NF2, as we just discussed, is linked to meningiomas and schwannomas. Von Hippel-Lindau is associated with hemangioblastomas. This table is very important. So, to quickly summarize our tour, we've seen the difference between the infiltrative gliomas that grow inside the brain, the primitive embryonal tumors like medulloblastoma, and the compressive meningiomas that grow on the outside. And I will leave you with this final thought. We are rapidly moving from a world of morphology, just describing what we see, to a world of molecules. The future of neuro-oncology lies in understanding these genetic pathways to provide better, more targeted therapies. Keep studying, and I'll see you in the next class.